Hey guys, we've almost come to the end of this series on localizing the strokes. In this video, I'll be discussing about the posterior cerebral artery circulation stroke. So without a delay, let's begin. I hope you enjoy the video. Subscribe for more. I will basically be talking about the manifestations of PCA stroke. So if we see this picture, we can see that the circle of Willis is ascending upwards into the brainstem, and it is giving rise to these two arteries at the level of the midbrain, are called the posterior cerebral arteries. These arteries are basically running towards the posterior side of the brain. We can't see it here because of the cerebellum, but they are running posteriorly. So as they run, you can see here that just after the bifurcation, before the posterior communicating artery arises, there is this small segment. This one is called the P1 segment, and after the posterior communicating artery arises, the posterior cerebral artery is called, the segment of the posterior cerebral artery is called the P2 segment. Now if we have a stroke involving the P1 segment, we'll have different manifestations, whereas if we have involvement of the P2 segment, we'll have some other manifestations. So as you can see over here, we are seeing the left cerebral hemisphere. So posterior cerebral artery is supplying this area at in the occipital cortex as well as the inferior temporal lobe. If we cut the brain into two halves and see from inside, posterior cerebral artery is supplying this portion of the corpus callosum. So this is corpus callosum. This portion at the back of the corpus callosum is called the splenium. So the PCA is also supplying the splenium. This is very important concept to memorize at this point of time, because I'll be discussing about this structure, the splenium's involvement in one of the manifestations that we'll see later. So let's now dive into the manifestations of PCA stroke. So as I said, the posterior cerebral artery P1 segment it gives off branches that supply to the midbrain. So this is the midbrain, as well as it gives the branches that would supply to the subthalamic nucleus over this area and the thalamus. So if we put this out of the picture, these are the subthalamic nuclei that are located below the thalamus, and therefore involvement of the P1 segment, the proximal PCA, would result in midband syndromes that we have discussed in our previous videos. If you have not watched it, I suggest that you watch that video. And then because of the involvement of the subthalamic nuclei, there will be hemibalismus on the contralateral side, and because of the involvement of the thalamus, which is also supplied by the posterior cerebral artery, we may have Desiree-Rossi syndrome, which refers to the contralateral pain and sensory disturbances following a thalamic stroke in the PCA territory. These are the manifestations if the proximal or the P1 segment of the posterior cerebral artery is involved. Now if we have the P2 segment involvement, P2 segment means the segment of the posterior cerebral artery after giving off the posterior communicating artery. So P2 segment is running behind in this fashion, supplying the inferior temporal lobe and the occipital cortex. So basically we'll have the cortical signs if the P2 segment is involved. The cortical signs that we will see are the contralateral homonymous hemianopia, alexia without agraphia in left PCA stroke, like we are seeing the brain from the back in this picture. So this would be the left hemisphere and this would be the right hemisphere. In the left hemisphere we have angular gyrus, and angular gyrus is one of the important centers which is used to recognize the things that we see with our eyes. So this the fibers to the angular gyrus might be involved. So I'll explain this in the next few slides. So that would lead to alexia without agraphia. Alexia means you cannot understand what you read, and agraphia means you cannot write what you think. So if left PCA stroke is present, we have the alexia without agraphia because the language centers are present on the left side. And if right PCA stroke is present, this would involve this area called the fusiform face area, which is present in the right fusiform gyrus, and it would lead to prosopagnosia, which is not recognizing the familiar faces that one sees. Alright, now let's dive into explaining how these symptoms occur. Hemibellismus. Hemibellismus means basically the sudden involuntary flailing movements of the extremities. It is an unwanted movement that should not be present. So how our body is inhibiting the unwanted movements at any given time? It is because of the subthalamic nuclei. The subthalamic nuclei. What subthalamic nuclei do is, if you look at this picture, the subthalamic nuclei is present over here. It sends a signal to the basal ganglia. The portion of the basal ganglia where it sends the signal is this area called the globus pallidus internus, the GPI. So the subthalamic nuclei, it sends the stimulus to the globus pallidus internus and stimulates the globus pallidus internus. So globus pallidus internus, which is a component of the basal ganglia, now sends the inhibitory fibers to the thalamus. You can see the yellow line over here. So these are the inhibitory fibers that GPI sends to the thalamus, and thalamus is like a relay center. It relays to the motor cortex. If it receives the inhibitory fibers from GPI, thalamus would be inhibited, so motor cortex would also be inhibited, and there would be no movement. So this is how our body is controlling the unwanted movement. So think of the motor cortex as the commander who wants to go and fight with the enemies. All right, think of subthalamic nuclei as the gatekeeper, and think of thalamus as the relay center. So say the commander is over here, the enemies are on this side, and there is a gatekeeper over here. The commander says that I would like to go and attack the enemies. So it's his thought, right? But the gatekeeper realizes the situation and says that no, you cannot cross this gate and go outside. So this would be the subthalamic nuclei, and the thalamus is this road to attacking the enemies. So what would happen if the subthalamic nuclei is absent? There would be no gate, and the commander would directly, without inhibition, go and attack the enemies. So similar thing happens over here. Just replace the commander with the motor cortex. Motor cortex is trying to initiate an unwanted movement. There is no checkpoint, so it goes via the thalamus and then initiates the movement. So then we'll have something that's called hemibellismus. It is due to the involvement of the subthalamic nuclei. The subthalamic nuclei would not function, would not maintain the gatekeeping role, and hence there will be unwanted movement manifesting in a person. All right, now let's look at how alexia without agraphia occur. This will happen only when we have the left PCA stroke. So why only in the left PCA stroke? So you can see a section of the brain over here. You can see the two cerebral hemispheres. This one is the left and this is the right, because we are looking at the brain from the back. So what will happen in the left PCA stroke is, these two orange circles at the back are the primary visual cortex that see the words the primary visual cortex from both the sides communicate with the word formation area, that is the visual word formation area, which is present in the left side, specifically in the left fusiform gyrus. The VWFA then communicates with the angular gyrus, which VWFA basically forms the words out of the letters that we see, and then it communicates with the angular gyrus, which would convert the words into phonemes. Phonemes means it will convert them into sounds, right? So I'd like to draw an analogy here. Suppose you see the word dog. So what visual cortex does is it just recognizes this word as lines, shapes. All right, so it would recognize that this looks something like this, but it does not recognize what it actually means. So what happens after that is the visual cortex from both the sides, they communicate with the VWFA and recognize that the thing that is written is a dog. The word it means the word dog. But although we have realized that this word is a dog, we don't know what it means yet, right? So what happens after this is visual from the VWFA, the signal will transmit to the angular gyrus, and angular gyrus maps the words into phonemes. Like the brain will say to itself that this is the word dog. We call it as a phoneme. All right. Now that we have a phoneme, this phoneme communicates with the Wernicke's area, then to the temporal association cortex, then to the medial temporal lobe. It will go, the signal would travel in this manner, and then it would recognize that this word or this sound means a four-legged animal that can bark. It is pulling this out of the memory that is stored in the medial temporal lobe, specifically the hippocampus, and after that it would communicate to the frontal cortex over here and like put a context to it, like, yeah, what we are reading means a dog. Dog is an animal that has four legs. So basically what I mean to say is, from both the visual cortices, the fibers have to come to the visual word formation area that is present in the dominant hemisphere, that is on the left side. So the information from the visual cortex on the left side would go directly to its area on the left, but from the right side it has to cross through the splenium of the corpus callosum. So this part over here in the topmost figure, if you can see. So if splenium is involved, then this crossing cannot happen. So we have a stroke in the left PCA territory, or in this area over here. So what is happening basically is the splenium is gone, the visual cortex is gone, so the left side is not being able to process the visual information, whereas the right side is being able to process the visual information. But what the words mean, it cannot process, because the signal cannot travel to the visual word formation area that is present on the left side. So you can see the word, you realize that it's a shape, but you can't make a meaning out of it. So that is called alexia. You cannot read the word. For the writing, we basically require the pathway is different. Like we form a word in the prefrontal cortex, then Broca's area will will transform this word into a phoneme, then it will come to the angular gyrus, and then it would go to an area called Exner's area in the frontal cortex, and then it would communicate with the motor cortex to coordinate the hand movements to write the word. So basically we don't have the involvement of the area supplied by the posterior cerebral artery, so the writing involving this axis would be intact, whereas reading would be impaired, because reading is involving the splenium. All right. And by the way, do you guys know what would happen if the angular gyrus is involved, or you have a lesion in the angular gyrus? So if you have a lesion in the angular gyrus on the left side, so that is the dominant hemisphere, you would lose the ability to write as well as read, because angular gyrus is involved in the reading pathway as well as the writing pathway. So you will have in that case agraphia as well as alexia. So the lesion of the angular gyrus is called the Gerstmann syndrome. This is not related to PCA stroke, but I just want to tie it in over here. So in this Gerstmann syndrome, you'll have alexia with agraphia, just to remember this. And now let's discuss why prosopagnosia happen. So we have an area in the right side that is called the fusiform facial area, fusiform face area, that processes the information that we see with our eyes. What happens is, if you see someone's face through your eyes, it would go to the visual cortex, and the visual cortex would communicate just like communicating with the angular gyrus on the other side. You'd have communication to the facial fusiform area, which would communicate with different areas on this side to recognize that this face belongs to this person, and it would give an emotional response regarding that person. So drawing the parallels, on the left side you have the involvement of the angular gyrus, not actually the angular gyrus, but the the splenium. I'd rather say splenium, because this area is not, these areas are directly not involved, rather the crossing fibers are involved. All right, so you can't recognize the faces if you have the lesion over the right PCA, because if we have right PCA lesion, the say visual input to the visual cortex on the right side would be damaged, and even on the left side the visual cortex to recognize the faces should communicate to the facial area in the right side involved, and it would involve the splenium, the crossing through the splenium. So since that would be impaired, so the faces cannot be recognized. So to summarize, if you have an involvement of the proximal PCA, you'll have midband syndromes, hemibalismus due to involvement of the subthalamic nuclei, and Desiree-Roger syndrome due to the involvement of the thalamus. If you have a distal PCA stroke, you'll have contralateral homonymous hemianopia. Left PCA stroke would lead to alexia without agraphia, and right PCA stroke would lead to prosopagnosia. I don't think I talked about the contralateral homonymous hemianopia, but it is pretty easy to trace. So if we have the visual fields that the lateral side and the medial side of the visual fields, this would fall into the retina on the contralateral side, like the fibers would cross. The fibers from the lateral side would continue on the same side to reach the visual cortex, whereas the fibers from the medial side would cross to the other side before reaching the visual cortex. So if you have this left PCA stroke, then we trace these fibers. So the lesion is here, so we would lose this side of the visual field, and then we trace this, so we look at this side. So we are losing the right side of the visual fields of both the eyes if we are having the left MCH. So that is why we said contralateral homonymous hemianopia. And there is an important tie-up to this. There can be macular sparing in the PCA stroke, because the macula, it receives a collateral from the middle cerebral artery as well. So rather than having the visual field defect like this typically occurs in the lesions of the optic tract. In PCA stroke, we may have lesion like this. The central area is the macula, so the macula might be spared. We refer to it as contralateral homonymous hemianopia with macular sparing. Just remember this. So I think that's all for this video. I tried to include all the concepts involved behind PCA stroke. I hope that it helps. For the examination, you can just move to the last slide of this video and memorize the different manifestations, but if you want to understand the concepts behind this, I suggest that you watch the entire video. So that would be it. Yeah, have a great day, happy learning. See you in the next video. Bye.